Welcome, everyone. It's great to have you with us today. I am Rita Landgraf, and I'm the director of the UD Partnership for Healthy Communities, a cross-college initiative, and I'm also faculty within the College of Health Sciences. We are very pleased to host both Senator Coons and Director Carroll in our facilitation of the Delaware Opioid Roundtable discussion here at our Star Tower. I just need to put a plug in for the tower. We are a year old this month, and we are home to the College of Health Sciences. I hope you will have time to take a look around to see how UD is advancing the science of health in education, research, and service via our clinics and our labs. We are so pleased that you are able to join us today as we explore the magnitude of effort occurring in our state to combat the epidemic, the current status of our state's efforts, and how best to leverage federal resources in this effort. I now have the great honor of formally introducing the visionary for today's program. Delaware Senator Chris Coons is a humble man who continues to live his life with intentional purpose to make life better for others. He is a man of service to others, whether fulfilling the role of father, husband, public servant, neighbor, or friend. He is pragmatic and remains focused and steadfast on some of the most important issues confronting Delaware and our nation. His commitment to making a difference for everyday Americans has earned him praise from colleagues, regardless of their party affiliation, and constituents. Chris serves on the Senate Appropriations, Foreign Relations, Judiciary, Small Business and Entrepreneurship, and Ethics Committee. He is Vice Chair of the Ethics Committee. As you all know, if you're a Delawarean, Chris spent a decade of successful service in Newcastle County government, both as Newcastle County President as well as Newcastle County Exec. Prior to serving as county exec, Chris also worked as an attorney for Delaware-based W.L. Gore and Associates, and Chris previously worked for the I Have a Dream Foundation, helping at-risk youth stay in school, get to college, and build their lives, and he also worked with the National Coalition for the Homeless. Chris is not an official Blue Hen, but today we are welcoming you as one. He is a proud graduate of Amherst College, and he also earned his law degree from Yale Law School, while also earning a master's degree in Yale Divinity School. Now, Chris has seen the human cost of addiction for families and for communities across Delaware, and that has motivated him to work tirelessly with both Republicans and Democrats to help those struggling with the opioid addiction. In 2018, Chris's efforts led to the passage of a comprehensive bill to combat this addiction. This level of commitment, character, and moral compass is what brought him to us today, joined by Director James Carroll, head of the Office of the National Drug Control Policy, to lead us in a roundtable conversation on addressing Delaware's opioid crisis. It is my honor and a privilege to present to you Senator Chris Coons.
Thank you. Thank you, Rita, and thank you, everybody, for coming today. We've got a lot to learn from you, so I will be brief. As the director of UD's Partnership for Healthy Communities, as a longtime advocate in the public health space for those living with mental illness, and as a very successful Secretary of Health in the previous administration, you have done remarkable things in our state, Rita, to help advance at the state level and at the state and federal interface health in the state of Delaware, and I'm thrilled you continue in a leadership role here at the University of Delaware. We just finished a conversation upstairs that has led to a couple of interesting insights and ideas about how we might move forward together that I look forward to exploring with all of you. Jim, thank you so much for joining us today. Director Jim Carroll of the Office of National Drug Control Policy colloquially a position previously known as the drug czar, but no longer known as that, now the director of ONDCP, is someone who in his confirmation hearing and today in our visits to Brandywine Counseling, to the Drug Diversion Court, here to the University of Delaware, has shown me his character and his compassion. We both know what addiction does to families and to loved ones in a very personal way. And in a roundtable earlier today with people living with addiction and working through their recovery, I was really struck at just how thoughtful, personable, and engaged he is. This is a fight that matters to him. And so, Jim, thank you for you and for your great staff who've been with us all day, how hard you work, how frequently you travel, how much of your heart you bring to this. We are really grateful. So thank you for being with us here in Delaware today, Jim.
Thank you so much.
We have a remarkable panel here. Rather than having everybody go down and spend 5 minutes on who they are, we're going to break up and do substantive conversations and introduce each group as they begin. I want to thank all of you for taking time out of your busy days to be here, to contribute, to ask questions. We will have a Q&A session near the end after the panel presents. And to everybody who's on this panel, every one of whom is known to me and, frankly, to most of you, one of the things Jim has commented on today is just how tight-knit and small Delaware is. That's one of the things that should make it possible for us to make greater progress. Despite that close-knit nature and despite the significant city, county, state, and federal resources and the energy and initiative that we've shown and the ways in which families and advocates have been engaged in this public health crisis, the tragic reality is the numbers have gotten worse. We all need to just take a moment and think about the ways in which the number of Delawareans dying from overdoses has steadily increased. We have not yet turned the corner. We've made real progress in terms of understanding the nature of the addiction crisis in our state. We've made real progress in terms of coordination between law enforcement and treatment and delivering resources. But the raw fact is that more than 400 Delawareans died from overdoses, largely opioid-related overdoses, which was 55 more last year than the year before. I just did a town hall a few weeks ago where I just asked for a show of hands. Of the several hundred Delawareans in the room, how many had been directly impacted by addiction and by the opioid crisis? How many knew someone who was in recovery or who had died? And it was absolutely every hand in the room. Could I ask you for a show of hands, how many of you have had your lives touched in some way by addiction, by recovery, or by the opioid crisis in our state? And the reality is that may be the only question I can ask you in this current divided partisan environment in politics. This may be the one question that brings together conservatives and liberals, Republicans and Democrats, people from upstate and downstate, from every possible background. It does not discriminate. Families of every possible background in our society are struggling with this, and we have to do a better job in tackling it. So thank you for being here for this conversation today. There is no one silver bullet solution. We have to get better across a wide range of fronts. I am grateful to our state legislators who are joining us here today because of the leadership role that the state of Delaware is playing relative to much of the rest of the country. We're going to hear about drug diversion courts. Judge Surles is with us. We have one of the very first statewide drug courts in the country. We're going to hear about a boots-on-the-ground effort like Delaware's Behavioral Health Consortium to address the distribution of Narcan or naloxone to the hardest-hit communities. We're going to hear about the Hero Help Program from Newcastle County Police and Department of Justice, State Division of Substance Abuse and Mental Health. We're going to hear about a number of different model programs. And we at the federal level are making progress both in passing laws, in enacting and introducing laws, but also in funding. Last year, on a bipartisan basis, we appropriated an additional $3.7 billion. It is not enough. It is nowhere near enough. We passed 70 bills into law in the last Congress. In the current environment, that doesn't get a lot of coverage. But these are bills that covered everything from research into better understanding pain, to training for physicians on how to manage pain, to better tracking and controlling prescription drug medication and distribution, to strengthening law enforcement, to authorizing new public health programs, to strengthening what ONDCP has available. And as an appropriator, I pledge to continue supporting this work at the federal and state level until we can have a conference like this and no hands go up. I also continue to legislate on this. I won't bore you with the details, but in the last week I've introduced more legislation with Senator Gardner. There are ways that we can and should solve this that are not partisan and that do not require us to get outside of our partisan foxholes. We just need to recognize that all of our families are struggling. So let me conclude and just thank the director and his staff for taking the day to be with us, and thank all of you for opening your hearts, for sharing your stories, and for listening. I think we can find some great answers together today. Director Carroll, thank you for being with us. We look forward to hearing from you.
Thank you, Senator. Thank you, Senator. It's great to be with you. And of course, we know each other from D.C., but what's great is to be here with you back home and to be able to meet so many people. When I'm on the road, I frequently talk about the partnership between federal, state, and local. Here, it doesn't really seem like that. It seems either federal or local, because the state is relatively small. And one thing that I've really been surprised at is everyone seems to know each other. So it seems like Delaware is really just one community. Today I haven't been in the more rural parts of the state, but certainly I'll say the top half of Delaware is certainly one community. And that's a great blessing, because what that means is that all of you are here and everyone cares. Like the Senator said, this is also personal for me. I have a family member in recovery, and 26 months ago, I didn't know that. I didn't know I would be saying that statement today. And like so many situations, it started with a prescription, but thankfully they came forward and said, I have a dependence, I'm addicted to this, and I don't know how to stop. So we were able to get them into detox. And now, 26 months later, I'm here as a family member also advocating for this. And it's interesting how life turns out for all of us. And what we know is that those of us who have been put in a position to help other people, here in Delaware, you take that very seriously. And I think it's important for you all to know that Senator Coons is a tireless champion for you all. One thing that's also been very clear is that you all are not shy people. I don't know. Has anyone ever told you that before? Senator Coons is not a shy person in D.C., and certainly his friends and colleagues that I have met here today in Delaware are not shy either. And I really don't want to talk much more. We're doing everything we can. The total government spend on this is about $36 billion, not counting the money that Senator Coons just helped pass. And it's a lot of money. But it's not enough, right? If we're all raising our hands, if more or less 200 people a day are dying from an addiction, we need to figure out how to work and what we can do better at. And that's the purpose of today's meeting. That's usually I'm at a hearing when Senator Coons is not being shy, I don't know if I mentioned that, about fighting for folks back home. But so thank you all very much, and I really want to hear from the panel and hear from you all. So thank you, Senator.
Thank you, Jim. Could we give him a round of applause and thank him for his leadership in coordinating our response to the addiction crisis nationally. Let me just remind you folks, there are index cards on the table. If you've got a question you want to ask, if you'd fill out a question on the index card, I'm not sure who's collecting them. JJ's in the back raising his hand. We're going to try and curate a few focused questions for that period. So JJ's going to collect the different cards. Could I also just take a minute and thank both Aaliyah and JJ from my office? A lot of other folks contributed, but they really took the lead in pulling this together today. So JJ, thank you very much. JJ Francis of Wilmington. Our first panel is going to talk about prevention and treatment. And we've got Dr. Carol Rattay from DHSS Division of Public Health, Chief Tan, who's all the way at the far end. So the coordination of this panel will be amusing to watch, who has long been the colonel in charge of the Newcastle County Emergency Medical Services Division, and Dr. Sandra Gibney of St. Francis. I've been a personal beneficiary of her care and attention when I was a patient at St. Francis, and I've been impressed by the way that Dr. Gibney has personally brought care to some of the most distant and challenged communities in Delaware. She and our Lieutenant Governor, Bethany Hollong, I've seen on a number of occasions, early in the morning, late at night, in the heat of summer, and in the depths of winter out there trying to make sure that there's health care available to folks who are genuinely living on the edge. So Dr. Gibney, why don't we start with you and then move to Chief Tan and then to Dr. Rattay, and just if you would share some comments about where you think we are in Delaware in terms of prevention and treatment. And we've got about 10 to 15 minutes for this. Thanks, Doctor.
Yep. I'm pleased to be here and honored to be selected. There's many moving parts to Delaware in addressing this problem, and I want to say that as a member of the Behavioral Health Consortium, the Addiction Action Committee, the Overdose System of Care, never have I seen this kind of coordinated effort that's occurring among many disciplines and agencies. So in that regard, I think we're unique and we have the opportunity to come together and solve this problem. I personally feel as if we've addressed areas, and in my mind, I break it down into pre-hospital, like our EMS service, in the ED itself, what we're doing for the doctors in the community, and what are we doing in the community itself. And I just want to quickly run, in a rapid pace to share with you some of the things we're doing. People may have recognized me in Lieutenant Governor going out on the street, and we've done 15 missions so far, and we've been at it almost 2 years. We've given over 2,000 doses of naloxone for free to folks in Delaware, and we try pretty much to get to those folks that are most in need and hit those folks that have demonstrated an area of a sick community that need help because they're having a lot of overdoses. Many agencies have assisted us in that. Office of EMS has provided us with a heat map, which shows us week to week. Every week I get a map, and we know where the overdoses occurred the prior week, and we direct our outreach in that regard. And personally, what we do is we meet the people where they live. We go to the community. On Monday, just 2 days ago, we had 7 shootings in Wilmington over a period of 1 week, and so we targeted that area to see what the heck was going on. So we went to 23rd and Lamont, and on 95-degree weather, and I kind of wilted a little, but we met the people where they live, gave out naloxone. Oftentimes, we give them other services, connect them to treatment, got 2 people in treatment. So quickly, and I don't want to focus on just that, because pre-hospital, we've set up a program to have, and I don't want to steal Chief Tan's thunder, but a leave-behind kit. So typically, if someone overdoses in the home, which we know is a very liable spot, that if they refuse to come to the hospital, used to be we'd say, okay, you don't want to come, goodbye. Now we've instituted a leave-behind kit. So that individual will get a satchel with 2 doses of Narcan in it, as well as information for treatment. And not only that, but they're going to get a call back from a program that's been started, which is basically a crisis response. So they will be visited again. So the opportunities we know to get care and get rehab is not always the first, the second, the third. It may be the 17th time someone addresses you that you get it and you're willing to get help. Dr. Rattay can also talk about our vision for a stabilization center where anyone, first responder or an individual, can show up and request help and get those folks into treatment. And we're already working right now forming mobile crisis teams for each county, to each county. So people like myself and other healthcare workers will respond to any kind of overdose or cry for help and actually go to that site. In the ED itself, I've worked hard to try to get other ED docs to prescribe MAT, medication-assisted treatment, Suboxone in particular. And we've been very effective in doing so, thanks a lot to the work of DSAM and public health. The biggest thing, and Elizabeth Ramirez, our director of DSAM, could tell us, is her START initiative, which is a computer program which takes every available bed in the state for rehab, for outpatient, inpatient, and at any time a provider can go on and see what beds are available and then match our patient or client to what bed and we put a request in, and then it's a form of communication. So that's been legendary to get people into treatment. From that, we've also embedded counselors in our EDs. Every ED in the state has a counselor there to help navigate an individual that wants treatment. used to be if someone overdosed, they came to the emergency room, they might be sent home. No one who overdoses in our emergency room gets sent home without Narcan. They're at high risk to do it again, so we do so. And then doctors. As a physician, I own a part of this. As an ER doctor, I prescribed a lot of Percocet. And so I felt an obligation not only from family members that struggle with addiction, but from a personal level of giving people. And I never thought for a second giving a week's worth of Percocet would create a withdrawal state and people who are vulnerable would struggle, but it happens. And so we've changed the laws in Delaware for ED prescribers, only allowing them to prescribe 7 days, no more. And also, we make it mandatory that they have to check the prescription monitoring program to make sure that that person hasn't received other narcotics or other substances that could also potentiate an overdose along with that. And also, our providers, I was shocked and a little bit appalled that a lot of doctors have no knowledge of what's going on. So with the help of the Addiction Action Committee, we formulate a webinar so that when you renew your license as a Delaware physician, you're mandated to take the training. So you have to be educated. And we hope in that regard that that will make a huge difference when physicians are prescribing in the community. And in that regard, we are also reaching out to a lot of physicians in the community and trying to get them to be prescribing medication-assisted treatment, not just in the agencies, but actually in private offices where people are more prone to feel more comfortable getting Suboxone if they're working and they're high level and they don't want to be seen in a certain area. They maybe want to remain anonymous. And then, thanks to Carol Rattay, mostly, I should say, we have an amazing website, but it's the best-kept secret, Help Us Here Delaware, which is an amazing portal, and we've been working really hard to create all the different education pages to that and updating that. So amazing things going on in that era. And then, obviously, the community. The state has had pods where we deliver Narcan to anyone who walks up. And as I said, Lieutenant Governor, and I wish she could be here today, she's in San Diego. You know, they call us kind of Batman and Robin, but she sends her best wishes, and I couldn't do it without her. So that's, you know, part of what drives me is that her passion and spirit to be right there with me. I don't know ever a legislator that would go out 15 times in the heat or the cold and in a homeless camp and squalor. And she does, and that's amazing. So we're so blessed in this state to have her. And I've taken up way too much time, but.
Thank you, Dr. Gibney. And could you just repeat the Help Is Here Delaware website? What's the exact address?
HelpIsHereDelaware.com.
.com. Thank you.
Yes.
Dr. Rattay, could you just tell us a little bit about what are the biggest barriers in Delaware to folks getting the treatment they need, and what are the biggest challenges posed to Delaware from a public health perspective by the addiction and opioid crisis? And then we're going to turn to Chief Tan.
Yeah, so, you know, when we, first of all, thank you, Senator and Director Carroll. We're very happy to be here on behalf of the Governor, Lieutenant Governor, Secretary Walker, Director Romero. We are working hard across cabinet agencies. And also, you'll hear me use the term we, and we involves, you know, everyone in this room. Collectively, we are doing a tremendous amount of work to try to address this incredibly complex issue, one in which, as you already said, there is no one quick fix. And so focusing on prevention, focusing on treatment, focusing on harm reduction, approaches in the criminal justice system and data and surveillance are all key areas in which we are working. We think a lot about prevention and how do we prevent addiction in the first place. And I feel it's important to spend a little time on that because while we're so furiously trying to save lives, it's important that we also simultaneously do all we can to prevent additional individuals from misusing drugs and becoming addicted. So on the prevention front, we've been working hard to improve how we're prescribing controlled substances and, very importantly, managing pain. Because one thing we've learned is Changing regulations around prescribing can make a difference, but we also need to give better options and alternatives to managing pain to really move the needle. So we're working on all of these pieces. Dr. Gibney mentioned a number of those, but it's a hard culture to change. We, very quickly went to a culture where we're prescribing opioids for every pain-related condition, yet moving the needle around that has been slow. But we're getting there, and we're really appreciative of the medical society and the many different partners that have come to the table to try to change that culture. Around treatment, I think no state in the nation was in any way, shape, or form prepared for a crisis of this magnitude. And so we sounded the alarm in 2011, and when Secretary Landgraf was in her role, and we worked very hard to increase the treatment capacity in the state. But this has been it's been a challenge because there are, quite frankly, just so many individuals in the state who are struggling with a substance use disorder. Nonetheless, the treatment capacity has increased significantly, well over 500% in the state. The Division of Substance Abuse and Mental Health and many, many partners have worked on developing a system that is comprehensive and coordinated and person-centered, meaning everybody's journey is going to look different. And we got to make sure we meet people where they are. The system needs to be high quality, and very importantly, we need to be engaging individuals when they're ready for treatment. We just released a report last week. 80% of individuals who died in 2017 of an overdose were involved in a Delaware health system at least once, and many were involved many times in the year prior to their death. We see those as opportunities to engage people. So Dr. Gibney mentioned the work in emergency departments, and you're going to hear more around what we're doing with in partnership with the EMS system. 70% of people were in an emergency department within 2 years of their death. Almost half were involved in EMS in some way, and many of those not for an overdose, but for a variety of other reasons. So this is why data is so important to us. It's really helping us shape, how we respond. But I would say, to answer your question, one of the biggest challenges and areas of focus is how do we engage people when they're interfacing with our system in a way where they don't feel stigmatized, and where if they're not ready at that moment, a certified peer counselor, somebody's following up with them. We're continuously finding opportunities to try to engage people or re-engage people into treatment in a humane and respectful way. I'll say the same for our Department of Correction as well. I also want to say harm reduction has been an important part of our strategy, and we are working very hard, but we're not clearly where we need to be yet. For every individual who may encounter someone who's had an overdose, we want to get naloxone in their hands and naloxone training to them so that they can appropriately respond and save lives.
Thank you. Thank you, Dr. Tay. Good news, bad news, we have a very large panel, and we are already 10 minutes behind, and we will struggle
That's my fault.
To conclude on anything like the timeline we'd set out. And we've got a wonderful director who's taken time here but has a train back to Washington. So, Chief Tan, if I could just ask you for a minute to talk with us about the Community Substance Overdose Support Program and what impact that's had in preventing substance abuse in the community, and how you see the role of EMS, as Dr. Tay was just talking about, as being the interface between the first responder community and then hopefully a pathway towards treatment and survival.
I think one of the things that we've seen as we've looked at this crisis has been, how do you quantify it? I mean, Dr. Tay talked about the need for data, and the reality is, as the public health crisis continued to escalate, the question became, how do you measure where we are in the community, and how do we quantify it and measure whether we're improving or the situation is getting worse? That actually gave rise to EMS taking a look at initially just Narcan administration in the field. How many patients were receiving naloxone or Narcan administration from EMS providers? And it also later developed into a monitoring initiative, a statewide monitoring initiative that includes EMS and public health data, law enforcement data, as well as the forensic sciences data that's now done on a quarterly and an annual basis as well. So you start taking that data from multiple sources and collaboratively putting out a report that provides that type of analysis. The Community SOS program was actually born out of a recognition that nobody was going to be able to address this by themselves. In healthcare, it's a collaboration. You have government entities such as ours that provide paramedic services. You have volunteer fire service providers that are nonprofit organizations. You have the receiving hospitals. You have law enforcement. You have a number of different agencies and providers that are involved in this type of response. And the question came down to, all right, well, how do we find areas to address this issue? And the first thing we did was look at process. And we were able to take a look and say, there's gaps when people are transported to a hospital emergency department, but they leave either against medical advice or they're discharged and not admitted, and they end up going back out in the community again, and we find that there's another EMS response and you have a similar issue. So through that, the Community SOS program looked at, can we do outreach for people that leave against medical advice or are discharged and not admitted for another issue? That actually evolved into a need to be able to reach out within a much more rapid period of time after they leave a hospital emergency department. There was really a 48-hour window of opportunity, if you will, where they would be best served to make opportunities for treatment available. So we've actually kind of developed the program even more where we're helping identify those patients so they can focus on them and actually make the community outreach. From a prevention standpoint, you know, I go back to when we looked at trauma years and years and years ago and had to develop a system of care. There was a statement that really the only true treatment of trauma is prevention. Once you're dealing with somebody who's got multi-system injuries, you're playing catch-up trying to fix a problem. That if you can prevent the injury from ever occurring, you're much better off. And I would submit that with substance abuse, we may very well have a similar circumstance, that if you can prevent someone from going down that pathway and getting involved in that problem, that may be the ultimate treatment for this type of a problem.
Thank you, Chief Tan. If I could, Colonel Bond, you're Chief of the Newcastle County Police Department. If you and some other folks who work with you want to speak up about the Hero Help program and how that has put police officers in a different role in terms of interacting with folks in a role where they're able to make a referral rather than just a sort of traditional law enforcement response. What made you bring that to Newcastle County? What's made it successful or not successful? And we have a number of folks immediately to your right. And the law enforcement community, I'd be happy if anybody would jump in and talk about how we're dealing with the law enforcement side of this significant public health crisis.
Excuse me. Good afternoon, everyone. Well, first of all, this program, the Hero Help program, was actually born out of necessity. In May of 2016, we started this initiative. Prior to that, we were looking at what is considered or has been considered our number one issue in Newcastle County, which is property-related crimes. For a number of years, as much as I hate to say it, we were one of the worst states in terms of property-related crimes. When we talk about burglaries, we talk about thefts, thefts from motor vehicles, things of that nature. What we found during the course of many of the investigations and when we made arrests was that many of the individuals, not all, but many of the individuals that we were arresting were individuals who were suffering from addiction. During the course of interviews, you will find when you would obtain statements from them, many of these individuals would say the same thing, that I didn't choose to be this way, I don't want to be this way, I want to change. There was it tugged at you, you realized that we had to do more. We would make the arrest, individuals would go away, they would come back out, and they would start doing the same thing over again. So what we decided and what we realized, much like many other agencies, is that we weren't going to be able to arrest our way out of this situation. That the best thing for us to do would be to partner up, with social services programs, the Department of Justice, DSAM, and come up with a program that was similar to one that was already underway in some states called the Angel Program. And as a result of that, we took on the Hero Help name, the moniker, and we started working closely with individuals that were arrested. And instead of them actually facing jail time, we gave them the opportunity to go and get treatment, to get help. And when we initially started the program, we could see immediately that it had the potential for success. However, we were running it as a police department. We had police officers that were in charge of it. And we did a good job. I think one of the things I was most impressed with and happy with was the fact that it wasn't just people going into the program that were arrested. The word was starting to spread, and we had people actually walking through the front doors of the police station saying, I need help, my son or my daughter needs help. Over the course of time, we realized that this situation and this opportunity to help individuals instead of arresting individuals could really grow into something that could make a difference in the lives of others. And so as a result, we were able to, after a few years, obtain grant funding and eventually hire on Dan Maas, who is seated next to my right. And just like any program, there's always good and bad to it. And Dan is
Is he the good or the bad? I couldn't quite tell what that look meant there, Chief.
I love him to death, and he does a great job, but he has really taken our program to another level. But it's not about us, it's about the individuals that we're helping. And I think that when I'll let Dan talk about some of the numbers that we have, but the number of people that we have entered into this program. And as a result, I think firmly believe that we went from a period of time we were having 1,700 burglaries, 2,000 burglaries a year, to last year having our lowest number of burglaries on record in quite some time, which was like 700 and some burglaries. And a lot of that has to do with the fact that some of the individuals that were committing these crimes were able to enter into the Hero Help program, get the help that they need, and as a result, not go out there and commit criminal offenses to feed their addiction. So it's been a tremendous opportunity for us, and we're continuing to grow it. That along with, we're also tackling, and I know we talked about the mental health. We have a mental health unit where we were the first agency in the state to have a mental health professional teamed up with an officer, because we're also finding that many of the individuals who are suffering from addiction are also dealing with mental illness.
Well, thank you. If I could, we are way behind our time on this very large panel. Daniel, if you have a few words you'd like to add about Hero Help and how it's played out, that'd be wonderful. We also are blessed to have our U.S. Attorney with us, David Weiss, and our Attorney General, Kathy Jennings, and you've both done things in your time of service at the federal level as the Chief Federal Prosecutor in Delaware and as our State Attorney General to focus our resources, to change the grounds for prosecution, to improve coordination between law enforcement, first responders, and the public health community. Please say anything you'd like to after Daniel briefly comments on the Hero Help program. Briefly.
Thank you for the opportunity to come and speak. One of the things that's important to note here is that pretty much everyone on the panel and a lot of you in the crowd have had an instrumental part in the development of this program. I think in a lot of ways it's demonstrated the viability of Delaware as an excellent incubator of pilot programs. What the police department has adopted with the Hero Help program is proactive problem solving. Addiction with overdoses may be what puts the individual on the radar, but then being able to go out and really work with the individual and the families, those impacted by the addiction, is shown a lot of promise. So I appreciate the opportunity to come and speak about it, and I look forward to hearing what the rest of the panel has to say.
So, good afternoon, and thank you, Senator, for the invitation to discuss whatever's on our minds. You usually don't get that kind of invitation, but the feds typically, in the drug arena, focus on drug trafficking organizations. So we got involved in the overdose death situation about 2 years ago for the first time. We established the first state overdose task force about a year ago because of the struggles that have been discussed already that the state has experienced. it has exposed us to issues, mental health difficulties, addiction, that we, in all candor, are not issues we typically deal with in our standard drug case, and it's been an eye-opening experience. So our goal in these cases is we respond with the assistance of the Drug Enforcement Administration and agencies that work with us throughout the state to an overdose death scene. And it's usually, there may be others at the scene who have utilized the same substance that caused the death, and there are family members and others around, so it's a chaotic experience. And we're focused, number one, on identifying what's taken place and trying to see if we can work that scene, identify the cause of death, identify whether the cause of death is attributable to a particular substance that we can prove caused the death, and then work off of that to try to identify those who sold the substance for profit, and we work up the chain. But in doing so, what we've encountered is, at the scene, it's often either a family member, a relative who has shared the substance, possibly an addict. They've received the substance from another addict who is selling only to support his or her habit. So it's brought us into contact with folks like Hero Help and Dan Maas. And what we've understood, and we're still grappling with this. We're talking about how to deal with these kinds of offenders, because they're distributing substances that are killing people. But we realize that the people we're really focused on are those who are selling those substances for profit. So what do we do with the addicts? And we're working through, how do we get those folks into treatment? As someone spoke about earlier today, they're in a particular vulnerable, exposed situation at these scenes. So it's an opportunity for us, if we're conducting things appropriately, to get them into the right hands, to get them into treatment, and then let the medical professionals work with them to see if we can sustain that treatment through the process. So that's what I'd say as to the Fed's exposure, and see what Kathy can add.
I'd say that's a novel role and approach for a federal prosecutor, and I'm grateful for the engagement of your office and the ways in which you've stepped up to this challenge. Attorney General Jennings, you've, in your first year in service, done some impressive things in this field. Please tell us something about it.
Thank you, Senator. And it's 8 months as Attorney General. And I have to say it's the best job in the world, because we get to help people every day. Along with that, this is one of the most challenging problems we face in this state and in this country. A little bit of a shout out to Hero Help, and in particular to Dan Maas. I have a friend in Sussex County whose son has been addicted forever. She has driven him to treatment probably a dozen times. Nothing worked. He was coming back time and time again, and in particular to detox. Last time she drove him there, Dan Maas happened to be there. He realized that there was a dual problem. There was mental health and there was addiction, and he got him the right treatment. This young man now has been sober for 8 months, and she credits Dan Maas with saving his life. You owe me, Dan. But seriously, I want to talk about and I know we are really pressed for time, but as Dave Weiss indicated, prosecution offices have started to treat addiction as the public health crisis that it is. And so on day one, we really tasked the prosecutors inside the Department of Justice to think about it that way. For example, we know there's a great interplay between low-level crimes and addiction. It's inevitable, and there is also the factor often of mental health issues. And so what can we as a prosecutor's office do to save lives, to help people on the path to recovery? Number one size does not fit all. And we ought to realize that we treat people as individuals when we look at the criminal justice system, and we need to and are diverting as many people as we can safely divert into treatment rather than a jail cell, rather than a criminal record, which creates its own problems. Second is there is no such thing as zero tolerance. I'm old enough to remember zero tolerance sentences that were imposed by judges. It doesn't work. It's counterproductive. There is not a linear path to recovery, and we asked our prosecutors to realize that and never impose a zero tolerance recommendation. We have learned over time that one of the main points of contact that people who are addicted have with the justice system, one of the first points of contact is with police agencies. And it was a real pleasure to help Newcastle County to work with them in the Department of Justice to set up Hero Help. It works. It has saved numerous lives. I would like to see us in Delaware scale that up. Scale that up among the larger departments that won't struggle as much with affording it because it is very expensive, and but for the grant, we may not have had Dan Maas at the county. I would like to see it scaled up with larger departments and smaller departments throughout our state. It works. It's a safe place for someone to go to get help. We have an ability to say to police, and we did it with Hero Help, if someone comes in on a really low-level crime, you don't have to arrest them. Get them help, and we'll work on the charge down the road. And so it's an initial point of contact. It's a teaching moment. It's a time when we can get people into meaningful treatment. So I would like to see those programs scaled up and us to continue to work to get Narcan, naloxone into the hands of as many human beings in this state as we possibly can. We have utilized asset forfeiture money for that very purpose in having Narcan distributed to police agencies throughout the state. I think that is part of our role as well, to make sure there is harm reduction, effective harm reduction out there. Thank you.
Thank you, Attorney General. I'm going to jump, if I can, to Judge Surles. Director Carroll and I had a chance to visit with you earlier today. Thank you for your leadership of the Drug Diversion Court. Delaware has a long and fairly strong history as one of the first states in the whole country to have a statewide drug diversion court system. And as you conveyed, Judge Gebline and the University of Pennsylvania really helped lay a strong foundation. Could you just briefly describe how it's currently working, what it's doing, and any areas in which you think it could be strengthened?
All right. Thank you for having me here. A drug court, or a treatment court as it's sometimes called, is a alternate track to the usual track in a courtroom. You come in, if it's on the regular track and you've committed a burglary, you come in, you plead guilty or not guilty. If you work out a plea deal with the state, your case is resolved at that point. If not, you have a trial. Maybe you go to jail. Maybe you're sentenced to probation. An alternate track is drug court. If you have a drug issue, you can come in and we can do it a different way. And the different way is to say, okay, you don't have to go to jail. You don't have to be convicted. You need to complete a drug treatment program. And if you successfully complete it, the charges can be dismissed and you go on your way. It's become a national program around the country, but there are still jurisdictions in the whole country that don't have a program. There are some that just started one last year. Delaware, we're the first state. We did it in 1987. So it's been going on here with Judge Rich Gebline started it in Superior Court in 1987. In the 1990s, I was a young drug prosecutor, and I got to staff that courtroom as the prosecutor admitting people into the court. The Attorney General was one of my bosses back then. I was a new prosecutor doing that program, and it was great. It's a little different than it is now today. Then you had to have no record, you couldn't have any prior drug convictions, and you could only come in if you had a drug charge. The Attorney General's office has been pushy about the program, and her prosecutors, other prosecutors at different times have come in and said, okay, well, why do they have to have drug charges? And I was like, well, we've always done it that way. And they're like, well, you can commit a shoplifting, or as Colonel Vaughn talked about, it could be a burglary, but the real underlying problem is a drug charge. So we eliminated that. Fine, come in on any charge you want to come in on. What's the issue we need? Do you have a drug problem, and do you want to get help? So in the last few years, we've switched it up to be open to basically any charge the Attorney General's office wants to bring in. And do you have a drug problem and are you ready to get help? So it's changed a lot, but Delaware's been on the forefront of this, one of the first states to ever get involved, and it's been going on now for more than 30 years.
Well, thank you, Judge. I'm going to, in the interest of time, I'm going to ask Jim Carroll, who's the ONDCP director, and Jerry Daley, who's the director of HIDA. If you've got some comments you'd like to make, I'm then going to turn to Secretary Landgraf, and then we're going to take your questions. We've got till 4 to accomplish all that. So, Director?
Thank you, Senator. I do want to be brief because I want to hear from you all. I do think data is key, and I think Jerry is going to talk about one of the data tools that we have. Where getting information on a weekly basis is great. We have a free tool that we've developed. Thanks again to the Senator Coons for funding the program. But it's nationwide, not just for Delaware, to allow real-time data in terms of where overdoses are happening, if it's an opioid that was used, if I see you have a got naloxone shirt on, ma'am. It's a beautiful shirt. And if naloxone was administered, how many times? Because what we're seeing is with the rise of fentanyl, naloxone being used more than once or twice, and it's a way for first responders to know how much to have in their medic units and the like. So there's lots of great information. I think Jerry's going to talk about it. But really, when you, Chief Bond, when you were talking, the thing that really struck me was, so often you think about the first responders and, their mission is to lock them up. What we are hearing here in Delaware is your first response, the first response of first responders is to get help for someone. And I think that that's why there is going to be success here. You have the leadership of the senators, of folks from the governor's office, the attorney general, but more importantly, the people in the community. And so I think, we're not going to arrest our way out of this. We're not going to treat our way out of this. We're not going to prevent our way out of this. We have to do all three simultaneously. And it sounds like that's what's working here. And so, Jerry, do you want to talk about some of the data that we can give away for free? Thanks to the senator.
Everybody likes things that are free, right? So one of the strategies that came out of what was originally called the heroin response strategy and is now called the overdose response strategy, recognizing the polydrug nature of our problems, particularly here in the Delaware Valley region, is a data analysis tool that both protects the privacy of individuals who have suffered an overdose, but also gives near real-time access to public health and public safety officials to visualize and pinpoint resources at an area that is experiencing an overdose situation that crosses jurisdictional lines. And that's the key feature of this. The OD map, the Overdose Data Mapping and Analysis Program, is one that is now in place in probably 2/3 of the country, states in the country, not necessarily in every community in those states, but a whole lot of communities have bought into this. And it identifies when, where overdoses occurred and what the outcomes were, whether it was fatal or non-fatal, and as the director said, whether or not naloxone was administered, and if it was administered, did it take multiple doses to revive the individual. Just those few data points are able to tell folks in public health and public safety, hey, we're seeing something happen in Newark, Delaware. We wonder if this is now going to bleed over into Bear, Delaware, or maybe it's going to bleed over into Oxford, Pennsylvania, or Elkton, Maryland. When we try to do this on a county level basis, we kind of bind ourselves to the artificial dotted lines that exist on maps and not the real world of how drugs flow through communities. So this is one tool that's come out of the overdose response strategy. It's there. I encourage you to look it up online, odmap.org. You can take a look at it and get a better sense of it than I can give verbally at this point. It's an important tool.
I would just mention that we do not collect any biographical information, names, there's no privacy information. We just want to know where it happened and what did we have to do to revive the person, hopefully.
Well, thank you. Let me ask, we've got two wonderful engaged advocates with us today. David Humes from Attack Addiction, who's from a personal tragedy invested a lot of time and heart and effort into making sure that policymakers don't forget that this is about families and about individuals at risk. And Joshua Stout, who I think I first met at Lyman House, if I'm not mistaken, who's been a great advocate as well. If you could just help us close this out and move towards Q&A with a sense of the challenges as you see them. One of the things, by the way, that we identified earlier, talking to Jerry Daley and to Jim Carroll, that Delaware's really not taking advantage of is drug-free community grants, grants that are $125,000 a year for 5 years. For a state our size, we should have 4 or 5 programs like this. We have 1. For those programs to be effective, they really have to be driven by advocates, by family members and community members more than they have to be driven, speaking for myself, you may not all agree with me, then they have to be driven from Dover or from Wilmington or from Washington. So Dave, could you just start us off with some thoughts on your experience and how you think we're doing in Delaware and how we could do a stronger job?
Thank you for having me on the panel. I appreciate it. Not only did I lose my son to an accidental heroin overdose, but I'm a person, if I make it through October, I'll have 32 years of recovery myself. That's not to get applause. That's only to let people know it's possible and people can recover and they can do some good things. When my son died, the investigating detective said to me, if we had a 911 Good Samaritan law or a Narcan law, your son might very well be alive today. And that was sort of what drove me. And as we sit here today, we've had seen various reports come out over the years, from the 2016 Surgeon General's report to the 2018 Delaware Drug Initiative Monitoring Report, to the 2019 Pew Report, and to the 2019 Overdose Fatality Review Commission Report. And they tell us we need more naloxone for the community. 79% of drug overdoses in Delaware occur in a home or a residence. And of those 79%, only 7% have naloxone. And we know that time is of the essence. I don't know what the current figure is, and maybe Captain Tan does, but at one point, response was 4.5 minutes to get to an overdose. If you're in Sussex County, I have to think that's more because I would think it's heavily weighted toward Newcastle County because we have a lot of good coverage there. So it's really imperative that we get more naloxone into the hands of the community and into the homes of people who are in use or suspected in use. So that's one area where we can do a better job. We didn't get to talk about education, and I know Director Landgraf wanted to talk about that a little bit, but I think a thing that's needed here in Delaware is a recovery high school program, so that when young people have to leave the state, and if they have to get treatment and they come back, we're sending them into the same environment that they came out of, where they got into it to begin with. So I think we really need, we're not talking about a school, Brooks, brick and mortar, $20 million. We're talking about a program. We have programs for other things where people have needs in the state. We need this for people who have addiction issues as well.
Thank you, Dave. Joshua?
Yeah, so just in thinking about what everybody's been talking about on this panel, I've been reflecting on my own work on the front lines and time spent, here in Delaware dealing with this epidemic. And, I've really identified, at least in my mind, 5 things that we really need to visit and pay attention to. And this comes not only from my personal experience, but also my role in academia of doing research in this field too. And that's, first and foremost is stigma, and we don't talk enough about this, but even today, the term addict was used plenty of times. Rather than individuals with substance use disorders, right? In 1957, the American Medical Association determined that addiction itself was a brain disorder, right, and a disease. And so we need to really conceptualize that substance use disorder itself is a disease. It's not a personal failing, nor is it a choice. I didn't choose a lot of the time. There was plenty of times when I was trying not to choose and felt like I had no other options. So, we need to refrain from using words such as that and really focus on the disease itself. Second is, we continuously talk about getting into treatment, et cetera. One of the unfortunate realities is this is based on the 28-day treatment model, which is also, 28 days because of insurance. And the problem that we see is a lot of times with this being a brain disorder itself, it takes more than 28 days for that cycle to reset, usually about 3 months. So if we're pushing people into treatment that's only a 28-day program, we're really just putting a temporary Band-Aid over it. And so we need to look at long-term treatment solutions and how to bypass the problems that we see with insurance blockage here in the state of Delaware. That's pretty much creating like recovery apartheid. And, look for people to get into long-term treatment. The third, is we mentioned research and data. Let's pay attention to that research and data. A lot of these things have been coming out for a long time. A lot of this research has been in the public discourse for a long time, but it's still not necessarily getting heard, and that brings me to my fourth point of safe injection sites. And this is something that people aren't really talking about still, because they say it's going to promote drug use or anything like that. It's going to keep individuals alive. And that's the number one requirement for people to enter long-term recovery. We're talking a lot about naloxone, but we also need to talk about safe injection sites for if we want people to enter long-term recovery, they need to have a heartbeat. That's just the reality of it. So if we can start to push and destigmatize this idea of safe injection sites for individuals to have a place, where they can go, safely use with medical care provided, and also at that point in time, receive information on treatment services for when they are ready and willing to enter that path, But even if they're not at that time, we're at least going to make sure that they're not like the 79% dying alone in their homes. And so, also too, one last thing is, so much of the focus is on individuals entering treatment, but we're not really discussing people who have been in long-term recovery for a while, who then pick back up. 7 funerals that I've been to this year alone have been of people who were in long-term recovery that's over a year sober, picking back up. And that first time using was their last. I've lost plenty of loved ones, including a long-term girlfriend, to that same thing, who was in recovery for a long time, and the one time picking back up was also their last. So we need to focus on what are the resources available for those who do get sober, right? Because if it is a disease, and it's a progressive disease, we can't just stop at, oh, they haven't used for 28 days, problem solved. We need to continuously focus on how we're advocating for those in long-term recovery, what resources are available to them, and I unfortunately did not hear any of that mentioned or discussed today. So that's all I have. Thank you.
And one brief thought, if I may. Just to give a sober thought here, well, we're here today for the hour and a half. We're going to lose 8 Americans to overdose deaths.
Dr. Landgraf, if I could just ask you to address the education intersection with public health. You run the UD Partnership for Healthy Communities. As former secretary, you have a strong sense of the interplay between prevention, education, skills, treatment. Talk to that for a few minutes, if you would, and then the director and I have 4 questions between us that have been submitted by the audience, and we'll do our best to address them, and one of them raises exactly the issue you were just pointing us to, Josh. Thanks, Rita.
Thank you. Well, I think what we are learning is that this epidemic doesn't just belong to one sector, it belongs to all of us. And that academia plays such a critical role as a partner in a variety of ways. I know that we're fortunate to have Josh as a doctorate student, and he's based in the Center of Health and Drug Studies, an area that I know that he's very passionate about and actually engaging in research. So when we think of people with addiction, they're all in long-term recovery. Dave Humes talked about that as well. And so how do we support people in offering opportunities? And academia is one way, and actually engaging the people who have lived experiences in research, I think, is very beneficial. I know faculty here are already doing that. Some of our faculty are researching what treatment modalities actually work, and what else needs to be promoted relative to our treatment and ongoing care. Addiction should be viewed from the lens of a chronic disease, because it is a chronic disease. And also, I think in academia, we can do a lot relative to teaching. We can talk about addiction for far too long. Addiction was an anonymous disease, and to some degree, I think that has caused harm because we did not talk about it to facilitate it as a medical condition. We are starting now. What I saw was we actually started talking about it from that perspective because law enforcement started talking about it from that perspective. And I think that has actually facilitated this level of conversation. So, thankful that law enforcement talked about we're not going to arrest our way out of it. And then people started realizing this was not a character flaw, that it was indeed a disease. So I think in the area for academia, the university, you can just put in a search opioids and you'll see the magnitude of research that is occurring within this institution, as well as engagement and as well as supporting things like apps in order to access care through HEN, which is accessing care now and near, because even knowing that providers can locate beds, individuals out in the community do not have that same level of access. So to be able to have that for our individual community. So I would say we all have a responsibility relative to combating this epidemic. We all bring gifts to the table, and if we all share in our gifts, I do believe that we can resolve this issue.
Thank you, Rita, and thank you. Could we just give a round of applause to the University of Delaware for hosting us today, and to Rita for her leadership in public health. The first question I'm going to read was submitted from someone who self-identifies as a nurse at Kirkwood and who says, is concerned about short-term detox treatments and their effectiveness. And the question is, what's being done as far as treatment tactics for fentanyl? I assume that means fentanyl and other opioid addiction, substance addiction and abuse addiction generally, where the question is, how can you expect folks to fully recover in just a few days of detox? And I'd welcome an answer literally from anyone on the panel who wants to speak to that. My impression is, just to follow up on what Rita said, that you need to have individual medical determinations about what's going to work or not work on a personal basis. And some folks, a few days of treatment can really give them the leg up to address and tackle their addiction. But many, at least who I've known personally, have needed much longer periods, either of medically assisted treatment or of other treatment modalities. Who'd like to weigh in on that? I suspect.
To talk about the effects of fentanyl, and I believe I might have stolen this from Director Carroll at a national conference, this package of sugar contains 3 grams. If this was fentanyl, it could wipe out this room. And if we had it in a shoebox, it could wipe out Delaware. That's how serious the fentanyl problem is. And we have to have longer treatment to take care of that fentanyl.
Dr. Rattay, thank you.
I'm going to start by saying I'm not an addiction medicine specialist. So in speaking about the thinking that the Division of Substance Abuse and Mental Health and the many treatment partners involved have, the evidence shows that detox by itself can be very dangerous. And so detox can be very helpful, but it can't happen in a vacuum. It has to be part of the continuum of care and services for individuals so that you go from, a decrease in the opioid or whatever, drug is being used. Medication-assisted treatment is very strongly supported by the evidence as being, one of the most evidence-based approaches to helping someone get into recovery, and for many people staying in recovery. And so there's definitely stigma around that we need to call out and know that, we don't withdraw insulin from people with diabetes. Medication-assisted treatment is very similar. But I'll echo what has been said as well around recovery. It's a lifelong approach in which, it's a journey, and there are a continuum of supports and services that are helpful to people along the way. But detox alone is not the answer.
It's such a great question. What we know is the medication-assisted treatment works, and it works for the problem that's really, sadly, killing so many folks here in Delaware. other states don't have, the addiction crisis that we have in the U.S. is interesting when you look at that geographically. Other areas of the country are really hit hard by use of methamphetamine. There is no MAT, there are no medications to help. So thankfully, there is at least medication here out there that can help folks here in Delaware. And we have to think of it, maybe, I like to think of it as Lipitor. I take Lipitor every day for cholesterol. If I was perfect and ate a strict vegetarian paleo diet and worked out for an hour a day, I wouldn't need it. And some people might choose that. They might decide to become clean and stay clean without MAT. But we have to allow people to make that choice for themselves and make it with a trained physician, have that doctor-patient relationship and figure out what is best for people. For me, sadly, I'm probably going to be on Lipitor the rest of my life. And that's how we have to think about MAT, is keeping people healthy and safe and alive the rest of their life and understand. One of the problems that we're facing, and Senator Coons has been a leader on this, is making sure health insurance companies pay for medication-assisted treatment just like they should pay for any other disease. This isn't hard, and it's a law. They should follow it. Yeah, thanks Senator Coons for that. I am hosting an event on September the 1st, I believe, first week of September, on this very idea of parity for insurance companies. If they treat mental health, they should treat others. And I'm having insurance companies come to the event. And the first one, we're claiming, my staff won't let me use the first one is sort of a hall of fame of insurance companies that are doing the right thing and providing parity, helping folks with recovery along those along the way. But I'm hosting another event later. I used to say that I was going to shame and bully them for not providing parity. I'm now supposed to say hall of shame, so I'm not going to say I'm going to bully anyone. But if you're not following the law and providing parity and providing coverage for people, what the heck? I'll bully you. I'm sorry, my staff is here. But you should, we should shame them into not providing coverage. And I intend to do it. But thankfully, we do have a Hall of Fame first. We have some insurance companies that are doing the right thing. And in terms of one other thing I want to mention in talking about stigma, if you're prescribed an opioid for a legitimate pain purpose, the doctors, and we've talked about this, should co-prescribe naloxone. And there's actually some pushback on this because I'm going to pick on the Attorney General. If General Jennings had surgery and the doctor handed her a prescription for a painkiller and said, oh, here's naloxone, some people would say, oh, well, I'm not, why would you prescribe that for me? Why do you think I'm at risk? I'm never going to do this, and they would be offended. Now, we know General Jennings wouldn't, but some people are. We have to get over that stigma as well and say it's just like having a fire extinguisher in the house. That doesn't mean you're a pyromaniac. It means that one day something might happen. Someone might get hold, of a prescription that's in the medicine cabinet, and you want the fire extinguisher of naloxone to put it out. So pushing, co-prescribing, getting over that stigma as well, getting over the stigma of doctors not willing to provide MAT for their patients. So there's a lot of good work being done by Senator Coons, pushing people who are reluctant along the way. And so there are some good things being done.
I think you get to read it.
Okay. I'll do the next question. What role does prevention play in this fight, in particular with young elementary and middle school age children? I think we've talked about it. It's huge. If a person has treatment or needs treatment, which there's about 20 million people we guesstimate in the U.S. who need treatment, they're already in active addiction. We need, obviously, to stop that ahead of time. Look, I'm very fiscally conservative. It's the right thing to do from a fiscal perspective as well as a moral perspective. For every dollar that we spend on prevention, it's a $17, $18 return on investment because we're not providing the cost of treatment. Put aside the moral cost, which should be the driving force on all of this, of saving their life and not having. So for any of the folks, that believe, oh, that's money wasted, no, we know that it works, and we're happy. And again, thanks to Senator Coons, my office is able to fund $100 million worth of programs across the country targeted at kids 18 and under, not only so they don't use opioids, but they don't use any illegal substance. We don't want teenagers drinking alcohol and smoking pot and smoking cigarettes. And so with the work the Senator Coons is doing by giving the funding, putting it back in the communities, we're trying to push prevention out. I know the prevention program has been discussed, but that is one of the things that I really do think we have to do. As I said, we're not going to treat our way, we're not going to arrest our way, we're not going to prevent our way in isolation. It's everyone at this table working together to do everything we can.
Thank you, Director, and thank you for your passion. Thank you for your genuine, heartfelt engagement in these issues. I've got one last question from my side. I know Jim has one more. How important is it to consider the option of holistic and/or homeopathic solutions as a means of treatment? I am not only not an addiction treatment health professional, I'm not a health professional at all. So I'll give you a completely ill-informed and superficial response from me, which is we need to use every possible means of treatment that could work. Some people respond well to acupuncture, to homeopathy, to massage therapy, and there are some folks who will only change their trajectory with medically assisted treatment, and I think we have to be attentive to what the needs are. How about if someone who's actually a medical professional responds?
I'd be happy to. And actually, Dr. Rattay can chime in as well, as we've looked at alternatives to opioids in treating pain, chronic pain, as well as we all know that there's an endorphin, which is a natural produced opioid when people do repetitive exercise to a certain extent. And I'm not afraid to admit that I am an exercise addict. And so I have a need for opioid, some tickling of that receptor, and I get it through exercise. And people that have sustained recovery have shown that a lot of times exercise is very beneficial for them as a stress release and also to create a little bit of endogenous opioid effect and endorphins, I should say. But we do know that everyone these days has different ways of whether it be biofeedback, massage therapy, acupuncture, acupressure, yoga, and we've looked at that. And we actually engaged different studies from throughout the country. We involved Oregon, and were able to get a study from Oregon who really looked aggressively at other alternatives to opioids, and they were pretty emphatic about which disciplines worked and which were effective for treating pain. So we really drilled that down, and I would encourage looking at Help Us Here Delaware's website, because we hammered out all those things, and there's references to where to locate those services. And more to follow with that. We're hopeful that the insurance companies will soon recognize those alternative treatments and cover them robustly. And we have made ground in that regard as to the number of treatments are no longer capped for certain alternative treatments, and there's more to do. But certainly I think Dr. Rattay can speak more about it, but we've worked really hard on and looking at alternatives and not ever denying anyone who has legitimate pain an opportunity. And, recently had experience where someone was in recovery and they were scared to death to get an opiate. And we had the discussion of, does that mean you'll never, ever get an opiate if you were addicted to opiates? And this has come up. And there's a difference between medically prescribed, supervised use in an acute critical setting and misuse and misadventure. Not to say that folks can't get triggered, they can. But again, we have to live in the real world with real people and people, places, and things. And so we have to learn to accommodate and adjust to society and be able to deal with the demons of addiction. So I think part of this is recognizing any kind of alternative that's helpful.
I'll just quickly say, I'm not positive if the question was about approaches for pain management or approaches for substance use disorder, which are different. As Dr. Gibney was saying, we are doing a lot of work around alternative approaches to pain management, and what we know clearly is opioids are most of the time not the best approach for managing pain. As it relates to substance use disorder treatment, as many effective tools as we have in the toolbox, the better.
And Secretary Landgraf was quietly saying, we've got lots of research on this. We've got research on mindfulness. We're doing research. We're at the university. They're doing research. That's a great thing. Thank you, Madam Secretary. I'm going to ask Director Carroll to bring us home with one last question, then we will make very brief comments. We have had a 14-member panel today. Everybody's had a chance to speak, and we've taken questions from the audience. I never believed that would happen by 4 o'clock. In 4 minutes, we might actually make that happen. Let's see, Jim.
Okay, I'll be quick. Prescription opioids have decreased. Doctors and pharmacies are now cross-referenced in the database to decrease doctor shopping. This is increased heroin trafficking. What is being done to address drug trafficking? All of the drugs that are killing folks in Delaware, all the folks that are 99%, whatever the percent, that being killed folks across the U.S. are being manufactured outside the U.S. The fentanyl that is so prevalent here in Delaware, the origination source for most of it is China. And it's either coming directly from China to the U.S. or increasingly it's going to Mexico in a either finished form or as precursor chemicals, and then final production is happening in Mexico and coming across. One of the things that is being done at the federal level, and we've talked about this, is I'm going to China in 3 weeks with law enforcement folks to hold China accountable for the drugs that are coming into this country. They're becoming the drug dealer of the world, and they don't like that title. So I use it a lot because, talking about the shame of that, we have to convey to them the impact that it is having on their reputation. I don't know that they really care, quite frankly, about what's happening to our neighbors and our family and friends, but they care about their reputation in that global setting. I'm going there and I'm pushing it. We've got the Chinese to do class scheduling of fentanyl. Senator Coons is pushing for more legislation on this front. Our high-intensity drug trafficking area, again, that we're able to fund out of my office because of Senator Coons, works on just that. It says HIDA, but it's high intensity. It's where the drugs are concentrated. And it's through, just like the data that we need for treatment and prevention, it's better data that we need for law enforcement. And so I think that's one of the things that's going on, is really securing these drugs from coming into the country. And with that, Senator Coons, thank you so much for inviting me. It's been a real honor to spend the day with you and to hear from so many folks across, I'd like to say across the state of Delaware, but really it's a community. It really is. And I feel that when I'm here. And so I really appreciate you all allowing me to come and, more importantly, telling me what I need to know so that we can continue to do a better job of saving more lives here. Thank you, Senator.
Thank you, Director Carroll. Thank you, Director Daley. And to everybody who's on this panel and everybody who came and joined us in the audience, thank you for your time and attention. We haven't yet found the solution. We haven't yet turned the corner on this, but having law enforcement and public health, federal and state and local advocates and professionals around a table, having a real conversation, trying to get our resources and our thinking aligned on this is a critical step. So thank you to the folks who've come out today. Thank you for your investment of time and energy. And Director, thank you for what you do, because I know you're on the road virtually every day. You and your staff travel all over the country. The resources that we give you, I'm convinced you are spending wisely, and we frankly are looking to give you more in the coming year. So thank you all very much. Thank you for joining us.